I'm Buck and I've been a dentist for 16 years. Today I'm going to show you every step of getting an implant crown. I mean everything from extraction, planning, healing, surgery, and the final crown. This is an x-ray from the first time I ever saw this patient. I warned this patient of this dark spot around the tip of the tooth and that this was an infection and the tooth needed to come out. And then I didn't see her again until she came to me 2 years later and she was in bandages and stitches, as you can kind of see here on the side of her face. And so long story short, this patient went into a coma and almost died because the tooth infection started uncontrollably spreading throughout her head. Now, after the patient is numb, I start by pulling the gums from the tooth. And then I take an elevator and start putting pressure on the tooth. And let me say, this is going to be a very difficult extraction. Going back to the x-ray, the roots are long and somewhat curvy. And can you see the ends of the roots, how they're somewhat bulbous at the end, meaning they're bigger at the bottom than towards the top? This means that even when the tooth is loose, this is not going to have a good pathway out. And to make it worse is that when teeth have already had a root canal on them, the tooth is very brittle. So as I put pressure on it, it's likely gonna break. And then furthermore, on top of all that, I need to preserve the bone as much as possible since we need as much bone as possible for the implant. So I don't have a ton of options here to work with. But since the tooth isn't budging from my pressure, I have to cut a slot through the back side of the tooth so that it has space to at least start to wiggle free. And you can see as I put pressure on it, it starts moving a little after I do that. But as I do that, it's helping a little bit, but it's not helping a lot. So then I pull out my forceps to start putting pressure in different directions on the tooth. And that is when the crown that they have pops off of the tooth. And that might seem like a bad thing, but for us, it's actually a good thing because there's gonna be more space for the tooth to move while I'm putting pressure on it. And so as I'm putting pressure on it, it's still just not budging enough for me, or it's not budging much at all, I should say, even after quite a bit of time. So now my next step is cutting the tooth in half so I can take the tooth out one root at a time. And now all the pressure that I was able to put on the whole tooth, I can put just on one root. So once I make a slot down the middle of the tooth, I use my elevator to wedge and split the pieces in half. And now you can see when I put pressure on the tooth, only one root is moving at a time. And it is moving much more than it was before. But here's the issue. The tooth now starts to break since it is so brittle and weakened from the root canal and a life of just being drilled on too much. And since that one has fractured, I'm gonna try and remove the other piece of the tooth first, and eventually that piece breaks as well. So now, as you can see, this is getting really difficult. It was difficult from the beginning, but now it's gotten to that point where it starts to become really difficult. The next step is to cut slots in the remaining tooth and remove as little bone as possible. These slots are places I can fit my elevator to apply that prying pressure on the tooth to try and get it to mobilize. Now, since I can't do that, there is one spot on this tooth where I'm able to remove a lot of bone. That won't affect the final bone height much at all, and you'll see that. I can remove as much of the bone that was between the roots as I want. And so if I have to create some negative space for the tooth to move and wiggle into, that will ultimately give space for these roots to move, and it won't affect the final height of bone much at all. And I'm skipping through a lot of the procedure because this extraction took a very long time. But you can see the roots still break every step of the way. And just so you know, you can watch my other videos. I don't take this long every time. In fact, some of them come out very quickly. You may notice as I'm skipping through that at every step, the roots are getting smaller, but a little bit looser as well. But as you can see, it still won't come out. And remember, that is because of that bulbous root. These root tips were never gonna come out unless you did something like I did here, drilling away some bone. And then a while later, as I'm focusing on the second piece, it also starts moving, but it just gets too short to capture on this video. So I'll show you kind of where it happens, but you won't see much. But after all that, you can see that that root tip is very loose at this point. I turn my head and my assistant suctions out that piece. So I didn't get a good focus on it. But however, with the tooth out and with that surgery she had in the hospital, this infection is gonna clean and go away on its own. After both pieces are out, Now we clean any granulation tissue left behind and flush the socket with ozone water. And that helps clean and fight any remaining infection that might still be there. Next, at this same appointment, we start filling the socket with bone graft, which is small pieces of sterilized bone that are smaller than a pebble, but bigger than a grain of sand. And we fill that socket with thousands of these little pieces. And once they're wet with a sterile solution, they all kind of clump together so that you can start packing them into the socket. And after the socket is full, I will blot it so you can see what it looks like when it's filled up with all of those little granulated bone spicules. Now what you see will eventually fill in the crevices with blood, and it will coagulate, so it pretty much just stays in the socket and is lodged in there. But on top of the bone graft, what I'm going to do now is I'm going to place a resorbable membrane that will dissolve in time and help the gums heal slowly over the socket, because we don't want the gums to fill in the socket just yet, and we want to give a chance for the bone to heal first before the gums really start growing and integrating and attaching to the bone. Otherwise, the gums will tell the bone to remove a lot more bone. That's why we do that. So after that, I put a suture over the graft, which is really important to keep it all tight as possible so that clot doesn't really loosen up over the next few days and while the initial healing starts. And so as the last part of this first appointment, I take a Teflon membrane and I put adhesive on it and stick it to the top of the gums to block stuff from getting in it for a while. And that is how the patient leaves, with that little pink thing in there and the graft into place. Now, if the patient opted to have something temporarily fill this gap or space where they lost the tooth, then what we would do is we would put something temporarily over this as well that would look like a tooth in the meantime. But that does cost a little more, and so a lot of patients on back teeth, they don't want it. So now let's fast forward 3.5 months. Today we check and see how well the bone has healed and take measurements for the size of an implant that we will be putting in there in just a couple days. And as you can see, the bone looks nice and plump, and this tells us that removing the bone in between the roots did not do much damage at all. So also at this appointment, we take a panoramic x-ray, and so now we can measure the length of bone between the crest of the bone and an important canal that has important nerves in it running below, and those are the limits of where we want the implant to go. And we have 17 millimeters between the crest of the bone and that canal, which for a dentist doing implants is like an incredible amount of distance. And when you look in the mouth, the bone is just really thick and the height of the bone is spectacular. And as lots of dentists say, it looks like we have lots of good real estate to put in an implant. Now for me, I rarely do an implant longer than 8 millimeters long. And so I have 9 more millimeters longer than I actually need to do this procedure. And so unless it's an immediate implant, I mostly just use 8 millimeter implants. The reason why for me is because after 8 millimeters, they hold up great. They're as solid as a rock. And I don't go longer that because the longer they are, the more likely you run into complications during surgery. So as long as you keep the bone in front and behind the tooth and between the teeth good, then the socket won't collapse much as it heals. Now, after the appointment, we order an implant with the diameter and length we want. And that brings us to the next appointment where we place the implant into the bone. So after the patient is numb, we make an incision connecting the back side of the teeth. So we want to keep the incision on the ridge of the bone, but the further back, meaning kind of in the direction of the tongue, the better for this procedure, because then we can see more of the bone. But once again, we have to keep it on the ridge of the bone. We then use a periosteal elevator to pull back the gums. Now we're pulling back the gums just enough to expose the ridge of the jawbone. And so what you're looking at now is the jawbone. And now, since the outside layer of bone is really hard, we use a high-speed drill to put a divot in the bone right where we want the implant to go. Now what we do is we switch to a drill specifically for implants, and we make a pilot hole 8 millimeters long in depth, because once again, we are putting an 8 millimeter implant in there. The lines you see on the drill are measurements, so we know exactly how far down we're going while we are drilling. And now that we have the length, we use a series of drills that will slowly widen the pilot hole for every new drill bit that we use. Eventually the socket will be almost 5.7 millimeters in diameter, so our implant can screw directly in that socket that we've made and fill it completely and have the bone very tight against the implant. So now, as you can see, we've moved on to that step where here we slow down our drill and we put an implant onto the drill and it tightens down into place. So most of the time, the implant actually stops a little short of where we want it to go. And so what you have to do is take this instrument that is pretty much a ratchet for the dental implants, and you have to kind of hand tighten it the rest of the way. And so if it doesn't go down all the way after you've tightened it, then sometimes you have to take it out and drill a couple more times until the implant goes down all the way. And so now it's into place, and this is the most important part of everything, in my opinion, for the long-term success of the implant. Now, you may not have noticed this if you've never seen an implant, but what we have down there right now is an adapter piece that is screwed into the implant. So we unscrew that adapter piece and we take it off. And this is the important part. Once it's like this, we verify that the implant is down in bone all the way around the implant and not peeking above at all anywhere around the circumference of the implant. If it is, you have to back it out and then make adjustments and then put it back until it is all below or at the bone level. Now, I mentioned this because some dentists will do the procedure through the gums because it is quicker and cleaner of a procedure. But then, in my opinion, you can't verify as you're drilling how into the bone you are, and they do have ways around this, like there's guides and you can take CT scans to verify it all, but in my opinion this way is much more clear and straightforward, that you can see that that implant is all the way in bone with your own two eyes. And also, as I'm drilling into the bone, I'm not doing it blindly and I'm not relying on a guide, and sometimes those guides are off. That's why I do it this way, and that's why I mention that. And just so you know, I have never had an implant fail that has integrated with the bone. I have had one fail one time where the bone just completely never integrated and rejected the implant completely. But once that implant is integrated, I have never had one fail. And so now we very carefully smooth the bone all the way around the implant so that we can now screw a healing abutment and the future crown as well. And I do this at this appointment because in case I nick the implant while I'm doing that, I can just back it out, go grab another one and put it in there. So now what you're watching me do is screw in the healing abutment. And this healing abutment is made so that the gums form all the way around it as the gums heal. And so after the procedure and until the day you get the final crown, you will see this metal piece kind of poking through the gums for the next few months. And that is a good thing. However, sometimes if you have really active gums, they'll still grow over. And that's not necessarily terrible, but if your gums grow over it, the rest of the procedures will be a little bit more difficult because you'll have to be numb for those procedures. And if they grow nicely around this, then they'll be really easy because you won't have to do anything further with the gums. So to help them grow around the implant, we cut a slot in the gums and then we remove that little piece and we suture it all closed. And this is how it all looks when the patient leaves the practice. We also take an x-ray just to make sure everything else looks great, as you can see here in this panoramic x-ray that it does. Quickly, before I get into the most interesting part, I developed the best toothbrush, floss, and other dental products that are in Amazon affiliate links in the description. And these dental products are more advanced and will give you a stunningly clean mouth. You should watch my videos about why they are the best, posted at the end of this video, so you brush and floss with superior results that avoid gum disease, cavities, and give you fresh breath. Over the next 3.5 months, the bone is going to integrate with the implant and become extremely solid, like I've told you many times. But we check it 3 weeks later just to monitor the progress. And this is what it looks like at that appointment. Everything looks really great as far as the tissue is healing. I wish the healing abutment was a little more uncovered, and you'll see why in just a bit. But now let's fast forward to 3.5 months later, and this is what it looks like now that the gums have completely healed. So you can can see that a lot of that healing abutment is still covered, and it's just a little too much. So what we'll have to do is numb the patient and remove some of the excess gums, and that's what I'm just going to do here right now. So if it was a little more uncovered, we wouldn't have to do that because we wouldn't have to remove any gums. But now you can see me just kind of removing all of the loose tissue that I cut away. After that, we unscrew the healing abutment, and this is what the implant looks like underneath. Remember the adapter we used to insert the implant? So we're bringing that back now because that doubles as an impression coping, so we can screw that back down into the implant to 35 Newton centimeters. And once it is tightly into place, we seal off the top of that impression coping, and with what we call liquidam, we light set that over the top of it. And so with it all set like this, we're ready to take an impression. I like to take a closed tray impression with a putty and wash for this. And for the upper teeth, we take an alginate impression too, but my assistant did that on her own, and so I don't show that here. And so after that impression, everything looks good. So lastly for today, we uncover, take out that hardened liquidam, unscrew the impression coping, and we put the healing back on and choose a shade for the final crown. Now during the next couple weeks, the lab will put that impression coping back into the impression we took, and he'll screw a replica or dummy implant, and he'll attach the two. And then what they'll do with that impression, they'll make a stone model, and the implant will be oriented just like it was in the mouth, but now in the stone impression, and then they'll put this kind of pink fake gums around it. Now what you're looking at here is actually not our patient, but it is the same tooth on another patient. And what this does, this lines up the implant perfectly with the teeth, and they can build a crown that we know will fit in their mouth too. And this is awesome because it lines the implant up perfectly with the teeth next to it, and then they can build a crown that we know once it's done on that model will also fit into their mouth. And then once we get that back from the lab, we come to the final day where we can insert the crown again. Now you can see the gums once again grew over the healing abutment. So this person has very active gums, which means we have to number up and cut back the gums again. And since you've already seen that, I'll kind of fast forward through it. Normally, once again, we wouldn't have to do this. It's rare that this happens twice. But now what we do is we take that lab-made crown and we screw it into place to the 35 Newton centimeters so it won't come loose. We only do it to 35 Newton centimeters because if you put more force than that, it could strip the screw. And we have little ratchets and drivers that will measure the force that we're using to put the screw into place, because you do not want to strip this screw. And we are checking the adjacent teeth and how they contact each other, so floss snaps through. And if the floss snaps through nicely, it won't catch that much food. I try and get these contacts to be as wide as possible, wider than you get on natural teeth, because implant teeth tend to get more food caught in them than natural teeth. So a lot of dentists will make these contacts as broad as possible. And then next, we ensure the crown is sitting all the way down on the implant with an x-ray. We make sure the tooth bites nicely up against the opposing tooth as well. And so we're checking all these parameters. If it bites too high, then we file it down until it feels even. And then lastly, we make sure it looks good to both myself and the patient. Now you have to disregard the hole in the center of the tooth while the patient looks at this and explain to them that that will be gone in just a couple minutes as long as they're happy with everything else. And then if all those criteria are met, we are ready to seal off that hole, which has been allowing us to take on and off the crown. Once again, it's in there at 35 Newton centimeters, tightened into place, and I verify that multiple times, and I also check with an x-ray to make sure that the crown is seated all the way on top of that implant. And then, so once that's all verified, to seal off the tooth, we put a lot of Teflon into that access channel, and this creates a buffer, and we need this buffer in case we need to go in and take the tooth out again in the future, which will happen from time to time. If we didn't and we had to take this out at one point, we have to drill the stuff we seal it off with out of there, and if that went all the way down to the screw, we would mess up the screw and then we wouldn't be able to take it out. So that's why we put this little buffer area in there. Now what we do is then we etch the crown with this etchant, and then we kind of prime it, and then we bond. We put some bond in there, and we light cure and set that into place. And once that's light cured, then we take a white composite resin that we would use on normal fillings, and we fill that up, and we set that and light cure that into place. And so with all that set into place, we smooth that off and make sure once again that the bite is even, and then we give it a little polish, and this is what the final result is. Finally, we are there, and it's been a long journey, but you can see that this looks really nice, and the person's life has been saved. Once again, don't put off infections anywhere, ever. And then the patient is completely happy. And then this is a picture of the day I put in the crown. And now this is a picture of that crown way later, and you can see how nicely the gums have formed and how nice it looks. Now, a couple of notes. This is how I do implants for back teeth. It takes a long time, but is more predictable that way. The way we do implants on the front teeth is different, allowing us to do this all much quicker with better cosmetic results too. But that technique doesn't work very well on the back teeth, and it's much predictable to do it this long way. You can do it the fast way, but it just seems to be more successful and predictable to do it the long way on the back teeth. And so that is start to finish. And now that you've seen all the work that goes into it, now you probably even understand a little bit why these implants are so costly. It is a lot of work that goes into this little thing. Watch all my daily tooth care videos I have posted now for the best technique, tips, and products for a stunningly clean mouth that avoids tooth decay and gum disease and gives you fresh breath and white teeth. My dental products are in Amazon affiliate links in the description below this video. If in Southern California, my dental office is in the description as well. Like and subscribe to my channel if you have teeth.